Welcome, everyone. Thank you so much for taking the time to join today's POCUS Certification Academy, POCUS Bytes webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is POCUS and Neonatal Intensive Care Unit, and our speaker is Dennis Wood. Though officially retired, Dennis continues to actively teach and perform perinatal cardiovascular ultrasound. He works with MFM sonographers and fellows, neonatologists, nurses, and clinicians in both basics and advanced ultrasound, as well as point-of-care ultrasound. Over a career spanning 5 decades, he has collaborated with many of the field's most influential figures, and their mentorship shaped his work in fetal and neonatal cardiovascular physiology and ultrasound education. Dennis has contributed to global health efforts through his work with Project Hope and the World Health Organization, training fellows from around the world, many of whom are now leaders in the field. His work has taken him across the globe to present research, deliver lectures, and lead training courses. Welcome, Dennis. We're so excited to have you with us today and can't wait to hear your presentation.
Thank you, Daria, and I am very privileged to be here. So I'm going to share my screen. Well, good morning, afternoon, evening, or whenever you are watching this webinar. My name is Dennis Wood, and I have been loving diagnostic ultrasound since the 1960s when I had a work-study research job as an undergraduate, changing A mode to M mode ultrasound. I'm a big proponent of see one, do one, then teach one, and share what you've learned. This talk is all about volunteer teaching and the fact that you also learn as you teach. I will disclose that I teach pro bono volunteer and in 4 different NICUs in the Philadelphia area, and have been having the privilege to present research and doing teaching in the US and around the world. My purpose in this talk is to get folks to volunteer to teach and to get ultrasound imaging right. And I would specifically talk to those people who are doing MFM type ultrasound, because you do just about everything in the body and you look from toes to nose, which is what we're going to do. Why do we do POCUS in the NICU? Well, babies come out when they want to. They don't believe in schedules. They can't tell us what's wrong. 10% are premature. About 3% have birth defects, mostly congenital heart disease, and about 1% have HIE, which is hypoxic ischemic encephalopathy. And you've got to think that the mom had preeclampsia. But less than 1% of NICUs in the United States have ultrasound on site. Sick neonates are the most vulnerable cohort of any group of intensive care patient populations, and emergency treatment may be required immediately after birth or suddenly several days later. POCUS can give a rapid anatomical and physiological information even during active resuscitation efforts. Newborn ultrasound is safe, inexpensive, and portable, and can easily be taught by volunteers. And we can teach head to toe POCUS. We do cranial, neck, chest, lung, heart, diaphragm, abdominal, urogenital, spine, bone dysplasia, and vascular. All of those things are relatively easy and actually fun to learn on normals and then look for the abnormals. Also, we also teach when to call for help when you found something that you don't understand. Here's a case in point. This is a crashing full-term baby, about 3,250 grams, a newborn, and was intubated in the delivery room. Catheters were placed in the umbilical vein and in the umbilical artery, and the baby was sent to the NICU. Head cooling was initiated for HIE, hypoxic ischemic encephalopathy. Well, the next day, the baby started dropping its saturations and the heart rate was slowing and the blood pressure was crashing. Actually, the baby became pulseless, and this was cardiogenic shock. And very quickly, the fellow put on the ultrasound and saw that the heart was surrounded by fluid. And if you look here, you can see actually that the right atrium is being crushed. We told them to look at the aortic arch, make sure there was no coarctation, and immediately a pericardiocentesis was performed. As you see here, the needle, which is an artifact sound right there. And this is after the needle was withdrawn. Almost all the fluid is gone. The baby blood pressure came up, saturations came up to 100, and everything looked great for a while. And this is the baby 6 months later. Happy little kid. That's Charlie. All right, so what are the objectives for neonatology POCUS? Well, first, introduce the concept, and which is get it done quickly and look for specific things. You don't do the whole body for POCUS. Discuss patient safety, equipment, knobology, and understanding the basic ultrasound physics, which is really how to turn on the machine and how to hold the transducer. We discuss how to obtain ultrasound images of a newborn, 22 to 42 weeks gestational age, and we look from nose to toes. We look at everything based on what are we looking for what particular purpose, usually based on the physical examination or the saturations or the respiratory status. We think about something useful that might become a research job for you and get published. So what, when, and where do we do POCUS? Principles of ultrasound I'm going to do very basically, but we continue with every single session to talk about the physics of ultrasound. We do neonatal head imaging, and we talk about sweeping to get all different sizes and basically the same thing on both sides of the brain. We look cardiac imaging, how to do this very quickly as far and complete studies. We do lung imaging and talk about the A lines versus the B lines, which will tell us whether you have dry or wet lungs or pneumonia or atelectasis and severe RDS, whatever. We do abdominal imaging. We'll look for air and gas in the bowel, movement of the bowel. We looked at the liver and we look for hernias and congenital malformations. We do spine imaging mainly to look for abnormalities of the spinal processes, but also to prepare for spinal taps. We teach how to do line placement and position with vascular access. And we talk about setting up practice schedule and a competency checklist so that especially the fellows in neonatology can have a competency exam and a competency certificate. Over my time doing this, I've been very lucky to go from what my old boss called chicken scratch to now incredibly accurate pictures. And it's been a very good time for me because I can teach, but what I have learned from teaching is that I learn more as I teach. The problem is in Europe and Canada and Australia, they are using POCUS in NICUs, but not so much in this country. It's used by non-radiologists, ultrasound, which especially pediatric and adult cardiology, ICUs, and emergency rooms. Orthopedics is using it, and ophthalmology and anesthesia is now using it, but it's still rare to see it in the NICUs. This is my gift to the fellows in the programs. This is a thumb drive with a whole bunch of papers and also videos and lectures that we've given or copied off the internet so that they can see or go back and look at this on their thumb drive after we've practiced on a newborn baby. The first thing we do is teach where to turn the machine on. That may sound silly, but it really is important because some machines, the buttons are in a funny place, like for example, this one. We also teach how to hold the transducer, making sure that you don't push into the baby, especially in the chest and the fontanelles in the brain. And what we're looking for on a image that we get. And here we have an image of a complete atrioventricular canal defect, and the Z is in the same place as the marker in your hand. So that should be on the right. This is on the right. We do a little ultrasound, but mainly we talk about the ultrasound physics during the hands-on program. So we don't go over this too much because I'm sure almost everyone that's in the audience today is well aware of ultrasound physics. We use sector scanners and a linear transducer of very high frequency because we're looking at the most maybe 6 centimeters in. So an average of 10 megahertz is fine for our sector scanner, and we can use that on everything. But we use the high frequency for vascular work and for lung work and also for spine work. And we're beginning to use it for looking at the bowel to predict when a baby may become very sick from necrotizing enterocolitis. We'll talk about that in a little bit. The other thing we talk about is Doppler, and mainly Doppler color when we're talking vascular areas or trying to line something up appropriately. And here we can talk about the blue being going away as we look at what we call a pair of pants of the pulmonary bifurcation, and that's blue. And then there's a ductus arteriosus coming back from the descending aorta into the pulmonary artery, and that's red. So that's going away, blue, coming back, red. But there's also an orange in there, and that refers to the aliasing, or actually going faster than the setting that you have in your scale for your color Doppler. The ultrasound physics that we really talk about is attenuation, what the problems are, not being able to see, and which not on this slide, but make sure you use enough gel. We always say you cannot use too much gel, but you certainly can use too little gel and get a lousy picture. More about resolution, we talk a little bit about that, but again, we talk about it when they're having issues getting good pictures. Here's an example of a baby on an oscillator ventilator. And still you can get that and freeze the picture. And a lot of machines will allow you to have both a frozen picture with color and without color, and also moving pictures with that. We talk about artifacts, not just because they get in the way of looking at the real anatomy, but also we can use artifacts to tell us a little bit about what we're seeing. And so we want to talk, especially when we're talking about lungs, which is all about using the artifacts. Here we can see a stone in the gallbladder and how there's a shadowing under it. And there's also going to be shadowing under bones, but you also have a clear gallbladder. And so there's a through transmission, which makes the area under the liquid brighter. And so that's another type of artifact. When we look at the lung, we want to see the pleural interface. And really what that is air, and the air is reflecting back to us, but it also has reverberation lines, and we call those A lines. And this is a nice thin line in a normal lung. I have a lot of experience in fetal work, and these are pictures from a lot of different kids that we see. And fetal is extraordinarily useful in seeing things in the head, especially, but also for congenital heart disease and just about every other major structural abnormality, but also bony abnormalities we can see. It's a whole lot tougher in a newborn baby, especially when they're screaming and kicking and they're just hungry or something. In any case, we still want to talk about how to get the better picture with how to hold the transducer and talk about texture, contrast, and grayscale. The main thing we always go over, and that is between babies, is to clean the equipment and make sure when you're going in, you don't unplug something because you have to plug your machine in, and don't unplug the ventilator. We want you to plan on what you're going to be looking for. So we always, before we go to practice on a baby or see a baby for a reason, is do we need to see the head? Do we need to see the heart? Do we need to see the gut? Do we need to see the genitals area? Also, keep an eye on the heart rate and the O2 sats, and make sure that you're wearing gloves and that you're using warm gel. And don't forget to explain to the nurse what you're doing, why you're doing, how long you're going to take. And the main thing is down in this picture, that's a mom that's about 450, maybe 220 kilograms. You have to push. But on a baby, you absolutely should not push. You should glide on the gel. All right, so we'll start off with looking at heads. Newborn heads use fontanelles because the bone will very much occlude your images. So we go for several different fontanelles, and you need to know what it is that you're looking for. And also you need to know how you are and where you are looking. And so you have to know the normal anatomy before you start. So the fontanelles are the anterior fontanelle, which is the main one that we use. There's an occipital fontanelle, which we almost always find closed in term babies. There's the mastoid fontanelle, which we use to look at the cerebellum. And there's a sphenoid fontanelle, which we use to measure the middle cerebral artery and also take a picture of the circle of Willis and that type of anatomy. When we're holding the transducer, we want to make sure that everybody understands not to push. It's much better to use more gel and therefore get a better and cleaner picture. Always start by feeling the size of the fontanelle, because every baby, even in twins, the fontanelles are going to be different sizes. And we sweep once we get the midline, the sagittal midline, from side to side. One of the things I always teach is and ask is, who plays a banjo? Well, I play a banjo, but when you're playing a banjo, and as you can see here, you can rub the drum raw by just where you're balancing your fingers while you're picking with three others on the drum head of the banjo. So if you hold the transducer with your thumb and index finger and middle finger, your ring finger and pinky finger should be balanced on the skin or the head of the baby. Here we're looking in a cross version, and we really need just the two if we're looking quickly to see if there's hydrocephalus or if there's a major bleed. So all this can be done from the anterior fontanelle. We swing up towards the orbits, and then we swing back towards the cerebellum, and then up posteriorly towards the choroid plexus. This is looking at the temporal area, and we find the circle of Willis, and we can see with color just exactly where that is, and also where to put our measurement if we're going to look for changes in the vascular flow pattern. We talk about looking at the cerebellum, and here's the cerebellum, and this is from the mastoid. You feel the mastoid with your finger before you put the transducer on, and it feels like a zipper, and it's right behind the ear, a little bit lower, and you look down to find the cerebellum, and you look up to find the posterior lateral ventricles. We want to make sure that everybody understands what normal is. So I have pictures to show what a normal looks like. And we start off with in the front so we can see the orbits, and then move it back. And I have pictures for everybody to see that before they start. And then after they've done 4 or 5 baby heads, they pretty much can do that on their own. What we look for is equal on both sides, and here are the 2 anterior horns, and where the star is, that's the cavum septum pellucidum. And we want to make sure that everything is more or less balanced on both sides with no super bright areas. We talk about the fissures, like the Sylvian fissure here, but only in term babies, because you don't really see much in premature babies, especially 22, 23, 24 weeks. The other thing that we do is we look at this area as we're sweeping down smaller cavum septum pellucidum. Right above that would be the areas that we want to see as connecting. But this area we call the dancing lady, which is the cerebellum. And I show them a picture of Taylor Swift in a fancy outfit. I think everybody in the world knows Taylor Swift. And then we do our sweeps looking back and forth. And again, here's the lady dancing. And we want to see equal sides. But there's something wrong with this picture. We've lost all this. That's not fluid. That's because you don't have enough gel. So this happens all the time. People looking and maybe pushing too hard and they don't have enough gel. So here's another looking in the parasagittal midline. We look for the groove between the caudate and the thalami, and we want to look right above the groove as it becomes, the choroid plexus comes out, and see if there's any bubbles or teardrops or bright white areas or bright areas below that angle right there. And then we look down a little bit farther and out to the side to see how much gyri there are, and just how it looks, looking for bright areas. The bright areas would be about as bright as this. The other thing we look for is the standard position of different structures. And this is, again, the cerebellum. And then we've got the tentorium, and we've got the pons. But it looks very much like this picture. And that picture is from Claude Monet's Woman with a Parasol. Right? So that's what we look for. And then we get the gyral patterns. The main thing we're looking for is the corpus callosum. And if we can see the entire genu and splenium of the corpus callosum, that's good. We also look for the cingulate gyrus. We make sure that everything is pretty much equal on both sides. And here we have a baby that's a little bit younger. This is about 24 weeks, and we can see that cingulate sulcus, but at 36 weeks, we can see a whole lot more. When we're sweeping across, we see a little, this is not so much a teardrop as a bubble, and that's probably what will be called a grade 1 type of interventricular hemorrhage. And then when you turn the transducer 90 degrees, you can see it, improve it a little bit more, and also see what's happening in the anterior horns of the lateral ventricles. Here we have nothing around that area, but we do see something in a clot right here. And this is from the anterior fontanelle. And if you see something like that and you're not sure what it is, we go to the mastoid fontanelle. And we have the fellows, after the first couple of times that they've done heads, we have them look in this area for that particular clot that's right there. This is a grade 3 term where we've got a big bleed and a very thick area from the area between the thalami and the caudate. This is very thick and it's thickened, but it's also taking up a lot of space, and that's would be probably a grade 3. And you can see here in both sides of the gyri, and again, clots. But here we have developing hydrocephalus from that, and this might be at about 4 or 5 days after we had the bleed. And this is grade 4, where you've gone into the parenchyma, again into the parenchyma. And this is after we've seen some too much fluid in any place that we see it in the lateral ventricles. And this is the areas that would have been white before, now are developing into periventricular leukomalacia. And that can look like a lot of different things, but I always say it looks like teardrops and or masses of teardrops like this. If you have the cavum septum pellucidum, you should be able to see right here 2 lines and all the way across, because that's a structure that shares crosstalk between the right and left hemispheres of the brain. And this is where you don't see that at all. So that's absence of the corpus callosum. There are pearls for the newborn brain, and this is something that everybody should know who's in the program. But normal structures can be seen in progression, and it's all about sweeping and making sure that things more or less look the same in both the right and left hemispheres. The more premature the baby, the less sulcation and gyration that you'll see. The more premature the baby, the more spinal fluid you see. If you have a full term, you may not see much spinal fluid at all. But when we'll talk about HIE, you may be defining HIE by not seeing any spinal fluid. Almost everything that we do, we can see from the anterior fontanelle. And some of the babies are extraordinarily small, smaller than a cricket ball is their head. And we can see everything from the anterior fontanelle. But we do use the sphenoid fontanelle to look for flow in the MCA. And remember, do not push hard into the fontanelles. This is the way we find the midline. So we go until we see the ascending middle cerebral artery, and now we can see both lines of both the choroid plexus. And then we sweep around. And this is a little bit off. This is one of the fellows doing it. I tell them, try and make it equal on both sides. And if you can't, then there's an issue. And this is one that they couldn't. This is about a 30-week baby. But that's pretty good because they're keeping their falx right down the middle, and that's really what we want to touch base with. If they find anything wrong, they will absolutely get a radiologist to evaluate the baby's ultrasound study. So here again, we see another baby, and we see the corpus callosum and the callosal arteries, but here's the corpus callosum defined by that. Then we take the color off and we sweep from one side and then back to the other. Here's where you can see, obviously, something a little bit odd, and that was like a little teardrop in the anterior horn right next to the germinal matrix. And we sweep, and here again, not enough gel. There's a little bit more hydrocephalus. And of course, if you saw the hydrocephalus in utero, it's easier to see there. But there's a lot of issues here that we can see and use as predictors. But we could follow up on these babies as well. Causes of HIE include fetal ischemia, and maternal infection and maternal oxygenation. So if she's got asthma or pneumonia, things like that, and all lead to hypotension in the baby, metabolic acidosis, ischemia, and disrupted autoregulation. So we want to see that. And here we have no areas of fluid. All right, now we go to the PICC line. So the number one, let's say, where are structures? And the main thing that we're looking for here, if we have PICC lines coming from the arms, we want to see where's the veins coming across the shoulders and into the brachiocephalic vein or the SVC, and whether or not there is a persistent left SVC, because sometimes a PICC line from the left arm can go down and into the back of the heart because it's going through a left SVC. So we can see where those PICC lines are. I like to use the higher frequency linear transducer for that. But if we use if the PICC line's coming from the leg, we look through the, usually from the side, the same place where we would look for kidneys. We look for the IVC and look for the catheter tip in that position. We also can look at the trachea and see where the trachea ends, and that's almost always right immediately under the aortic arch, because that's where you have the carina. And we can see when we have this image, we can find the tip of the endotracheal tube, and we don't want the endotracheal tube down too far. This is where we really want to talk about how many x-rays can we see on babies who have lines put in or having the tube put in. I think that in my experience, when we intubate a baby, you listen for equal breath sounds on both lungs. but they still get an X-ray in a lot of NICUs. I saw one line put in a UV line where they had 6 X-rays to prove the position. We don't need to do that if we're using ultrasound. Okay, so this is what we call GORP, and that is in the baby's esophagus. But we can also see with the tube coming down, going into the right under the near the aorta. This is thymus. This is, I'm sorry, this is a line down here. So this is liver, and we can see this is a vessel down there. Really small babies. And here's one in the brachiocephalic vein coming from the left. And here we're looking at the heart, and we say, well, we really can't tell from the X-ray where the tip is. So we look in the heart and we can see, oh, that's something odd. And that's either a thrombus or it's actually the catheter. And you can see here in the screaming baby that the tip of the catheter is right across the foraminal valley. Here's the IVC, and here's the back of the left atrium. Here's another one. You see a little bit better, and you can actually see that the tip is in the left atrium. And this was a request because the baby was having premature atrial contractions. So they pulled the catheter back. Now, when we talk about line placement, one of the things that they really want to do is put something into either a radial or ulnar artery, or they look for the brachiocephalic veins. And we practice on each other and on the babies as well, not necessarily to do a stick, but rather to make sure we know where we're looking. And looking is pretty easy. And again, this is with a very high frequency transducer. So we're only looking at, in an infant, 1 centimeter down to find the vasculature. And this is how we're doing that. And here the vasculature is in, actually, this is in an adult because you can see a slower heart rate, but you can see the veins and the arteries, and you can see that we're only, even in an adult, at about half a centimeter. Okay, let's talk a little bit about the heart. The fetal heart is really a good study because you can see everything from any direction because there's no air in the lungs. Whereas when you're doing an adult or a child or a baby, the air in the lungs will get in the way of seeing the complete heart as well as this. Here we can see the foraminal valley that's popped over and open. We can see the pulmonary veins. But in this baby, we can see the same thing, but this is subxiphoid. So from subxiphoid, we can look up and with the color, and there's a small ventricular septal defect. And there's also a ductus arteriosus, and and there's a patent foraminal valley. So we can find a lot very, very quickly in just one sweep looking from subxiphoid. Now, this works very well on brand new babies, but as soon as the babies are a week or 2 old, they are going to be difficult because they don't want you to push on their belly. They're going to scream at you, kick at you, and smack you, do everything they can to keep you away from pushing on their belly. So that's a subxiphoid. This is from the 4-chamber view, or the apex. This is between the xiphoid process and the nipple, usually right in the middle. Here's another baby that's a different location for a ventricular septal defect and also had a patent ductus arteriosus. The thing that I teach is how is the ventricle working? What is the size of the ventricle, left ventricle compared to the right ventricle? Is the left atrium bigger than the right atrium? Yesterday we had a baby that the right atrium was bigger than the left atrium because the baby was born with premature closure of the ductus arteriosus. So the right side of the heart was very big. There was a lot of pulmonary hypertension, and we used things such as Doppler to find how much tricuspid valve the regurgitation there was. But we do that, and we can do that in just about every baby. Looking at the heart takes longer than just about everything else, but we want to make sure that everybody gets at least a 4-chamber view and another view, which we call the pair of pants view. This is long axis, And with this long axis, we can see the squeeze of the heart and the relative size, whether or not there's a ductus, as there is right here. We can actually measure things. And we've measured here the velocity of the ductus, which tells us what the relative pulmonary artery pressure is. Here's a ventricular septal defect, and that will also tell us what the relative pressure is. This is looking in a branch of the pulmonary artery, and this is a baby who has a murmur right before it's going home, and that is because of increased velocity in the branches. Here we see the pulmonary veins. Make sure all 4 pulmonary veins are. And we teach this, and again, babies with VSDs, we teach this because a lot of babies have murmurs. For pediatric cardiology, I think, who are trained in neonatology, you can hear a murmur on just about every baby. But there are some babies that have very loud murmurs, and some have murmurs that come and go. So it's a good idea to look at the heart before the baby is transferred home. This is called the arch view, and this is looking from the high parasternal area, and it's the best way to see the patent ductus arteriosus. And we look around and around, and we measure the velocity down below to make sure there's no regurgent flow back into the pulmonary artery, or reversal of flow in the descending aorta. Reversal of flow in the descending aorta also makes a steal on the SMA, so that can lead potentially to necrotizing enterocolitis. So we want everybody to understand why they're looking, how to look, and what it means. Here's another baby. And this is a relative ductus, but it seems to be a closing ductus. So this is one that's serpentine. And so this baby, although it's obviously with tachycardia and tachypnea, the baby may not need to have treatment. But if you have a large left ventricle with that, then maybe you will think about treating. The thing is, you can follow the baby from day to day to day, and you can see what changes are happening, how the ductus is closing, the size and function of the ventricle. This book again, it's a big left ventricle. It's a relatively small ductus. So this one would be let go for a little while. All right. Can ultrasound be used in NICU to augment chest x-rays? Well, the standard for looking at lung disease is the chest x-rays, but chest x-rays don't really differentiate as well as ultrasound, what we're looking for. So the first thing we do is we have a pattern of where we're going to look with our high frequency. And what we want to see is an absence or presence of A lines. In newborns, you have A lines and B lines. We'll talk about that in a second. We want to see the pleural line, see if it's abnormally thick, or if there's absence of movement, as in what you would see with a air in the chest. We want to see if there's an interstitial syndrome or pulmonary edema. We want to see lung consolidation and air bronchograms, which can tell us about the severity of the RDS. Also, we had a baby yesterday that they looked at because a baby had just gotten surfactant. And within about 10 minutes, it went from a really severe RDS to not so bad, still RDS. We look for a lung pulse for atelectasis. We look for differentiation between one lung and another for transient tachypnea of the newborn, TTN. And we also look for long-term oxygen dependence versus bronchopulmonary dysplasia that might lead to cor pulmonale. This is a great paper from 2017. They looked at 3,400 cases of newborns. And the main thing is they found normal, and they found oxygen dependent, and they found one of the worst things, which is meconium aspiration. but also looked at a lot of other things with TTN, RDS, and pneumonia, and what can you see, what can you find? And so they made up this slide for us to use in understanding what it is that we're looking for. And so here we have reverberations in the normal lungs, and here we have normal intercostal imaging. So the one before is where you're looking sort of longitudinally, and this is looking right straight from the axillary line into the chest. And this is looking in a transverse fashion so that you're between the ribs. We can also find a pleural effusion. We find it better in the fetus because we can see everything and there's no air in the lungs. But here we can see collapsed lungs, pericardial effusion, and pleural effusion. Here, this is irregular and thickened line. See this? It's very irregular. It's not a thin line. This is also another one, RDS. This is where you can see movement of B lines, and you really don't see the A lines, but that's because you have a thickened pleural line. And this is called the double lung point because this lung is better, but this lung has this ground glass appearance. So this is the difference between RDS and TTN, and that can be found immediately upon looking. It takes longer to plug the machine in than to make these diagnoses of RDS versus TTN. And most babies that are requiring oxygens and preemies are going to be TTN. And here again, we'll look at that and just look, and then you sweep all the way down to the spleen or to the liver where you see actual anatomy. And this is all reflection of artifacts. And you can see that that's a pneumonia picture. All right, so here's an X-ray. And what is this real X-ray really telling you? Well, it looks like you got bad lung on this side and a wet lung on the other side. So here we have TTN on this side. And in this one, we had RDS. So let's talk about abdominal sweeps. Well, first off, we want to see if there's free air in the gut, and that's going to give us a little bit of a problem because of big reflection. But if we have mural air, in other words, in the wall, that's indicative of potential necrotizing enterocolitis. If we have complex fluids like ascites or fluid around the bladder or fluid around the kidneys or under the liver, that's going to be complex fluid, and we can talk about it. We look for ovarian cysts because they may have been identified in fetal studies. We look for portal venous gas, which is usually after you definitely have necrotizing enterocolitis. We look for hernias, thickened bowel, malrotation, volvulus, intussusception. Absent Doppler flow means something. Normal flow patterns mean something. Pneumatosis is something that we look for really quickly, easily. And neck is where there's different things that happen over time with neck. We look for masses, hemangiomas, hydronephrosis, and bladder size. So that takes a little bit longer, but it can all be done in about 5 minutes. And the nurse won't get mad at you for taking so much time with her baby. Here we're looking at a liver, and this baby had a little bit of heart failure, and this was a portal venous shunt. And it was pretty quick to show that, and then it was proven by cardiology and radiology. Here's looking at a kidney, and it's pretty good. We tell people to feel for the 12th notch, then look as if you were looking at the spine. And if you put on the color, you can find exactly where the arteries and the veins are. And this is another thing that we teach about how to use scale to look for and to adjust the color. When we're looking at the kidneys, we want to make sure that we're not looking at hydronephrosis, and this is the Society for Fetal Urology grading system for hydronephrosis. But we've also seen urinomas, and we've seen multicystic kidneys. Multicystic kidneys are usually diagnosed in utero, but not everybody gets studies in utero. We can see funny looking but normal adrenal glands. They're a little bit harder for most people to find, but here is an adrenal cyst. That's usually just blood and it gets better on its own. Here's portal gas, and what you can see is all these reflections all over the place in the portal gas. Here's a thickened bowel wall, and we don't know the reason for it, but it's something that we can follow, and so that might be an inflammation. Here we're looking at pyloric stenosis. That doesn't happen usually in newborns, but kids that are there for a while. I have seen it in babies who have, super preemies. They can develop, just like any other kid, pyloric stenosis, and this is how you find it. This is a sweep. Looking at normal bowel, we want to see if there's fluid in the bowel, if there's stool in the bowel. We want to see the thickness of the walls of the bowel. We can put color on and see how much velocity there is and how much color flow. The more color flow, the more likely that you have an issue. And this is a baby that's got pneumatosis because all these little bubbles that go all the way around the bowel, in the bowel wall, not in the bowel lumen. All right. Here's looking at ambiguous genitalia, and what did we find? We found a couple of gonads, a couple of balls, so this was definitely a boy. Here's a question of very, very full, very firm scrotum, and we can see is that because you have bowel, or is it because you just have hydrocele? And you can see how long that took. And it doesn't take long to teach this either. This is different. This is a new thing that we've just told people. Those of us who are aged in looking at pregnant women know transperineal imaging. And this is a transperineal imaging on a baby that weighs about 1,000 grams. And you can see the entire uterus. And the question on this one was whether or not there were any kind of Mullerian agenesis, which was happening in the other siblings, and also if there were any other issues. This baby also had what felt like either a small tumor. Actually, it felt like a pill right in the inguinal crease. And what we found was that it was a fluid pocket and where it was coming from. So it's probably a lymph node, but it could have been a hernia and it could have been an ovarian cyst because of the baby had siblings with those issues. This, we believe, was just a lymph node. All right, now we go to the spine. And the first thing we do is we look at the spine in cross section. And again, this is looking in a baby that's about 1,500 grams. And the baby was said to have potential butterfly vertebrae. And so if you slide down, you can actually see what's going on. Then we go into a longitudinal and we look for the fimbriae and the conus. And we almost always, that's going to be right at L2, where the conus of the cord is. And then we follow it all the way up. And of course, the baby is going to be moving while we do this. This is when we see a tethered cord, the fimbriae seem to go right straight up. You don't necessarily feel anything on the skin. You don't necessarily see any kind of a hair pocket or a cyst, but you can still have that with you can still find the fibrous cords going up and sometimes thickening so and you can also rule out fibrolipomas. And here is a lipoma. This is a lipomyelin cell. And you can see at the end of the cord how this comes up. And you don't feel that necessarily, although sometimes it is association with dimples at the sacrococcygeal area on the skin. And here again, we can see the whole conus. And we can see the respiratory movements as well. And this is really an easy way to look where is the largest area of fluid. And this is a very good way of going or sliding up and down along the conus. And you want to find an area there where there's good fluid so that you can do your spinal tap. I always give them a magic marker to place where they want to see that and do that spinal tap. Okay, so for nurses, fellows, attendings, anybody who's taking the course, it is a 3-year program, and this because the fellows and everyone move around in 3 different hospitals, especially here at Jefferson, they're not going to be there every week. So we see them about 4 times a year for a full month. And on 2 days a week, we look at babies for an hour and a half, and that's our way. We do an introductory lecture. We do several times a year. We have a sim course here and a simulation lab with adult models, but they use that to get a good feel and good idea of where to aim. But you know, an adult model is so much bigger than a 350-pound baby. So working with the babies is really what we need to have the fellows do. In any case, this is a competency checklist, and when they have seen it, and every student will have this. And then we'll go through this and look at the different things that they want to see. For those interested in learning POCUS, and not everybody is, but our fellows are now sort of required in some places to do that, and in the 4 places I go, they're now required to do this. The main thing is to understand what normal is, and then to be able to do something really fast. So get in there, look at the heart if the baby is supremely cyanotic, things like that. Then we talk about the study plan, which is for them to practice on their own, because everybody in this business has to work through the nights, and they have some quiet nights when you can practice with the ultrasound. And then you keep a diary on a USB drive to show what it's done, and that can be used for their competency record as well. And remember that we always tell them, you may be good today, but tomorrow it's going to be terrible pictures, and that's because the baby's kicking, screaming, or whatever. Whereas today you have babies that are all intubated, and it's a lot easier. Always there are limitations, and always with very small babies, we want to make sure that the baby or any child, you don't use any pressure, you glide on the gel. This is extremely operator dependent, and therefore it requires practice. You have to position the baby and position the transducer within the isolate to give you it can give you a sore arm, sore neck, or sore back. Make sure that you're comfortable in the way you're holding this, because if you're really tall or really short, you can raise and lower the isolettes. Respiratory support equipment will always get in the way, but you want to not, knock out the tube. Lines get in the way, and timeliness and infection control is paramount importance. Make sure you're clean, always wearing gloves. Clean up the baby afterwards. Make sure that you have permission to practice, but also permission from everybody in the room, including the attendings, that you're going to do that. And if you're going to do a sterile procedure like a TAP, make sure you do have sterile coverings for the transducers. Remember, no abnormality can be identified by ultrasound or any other imaging technique unless you know and understand what and how the normal anatomy appears. I cannot stress that enough. You have to know either from pictures or from practicing on normals what it looks like when it is normal, so that you get that in your mind and you compare that what you have in your head's register as to what you're finding in the baby that you're looking at. These babies are sick. They're in the NICU. They want to go home. This is a preemie. It happens to be my granddaughter, and this is her guitar. She's a shredder. She plays the guitar and she plays violin as well. She had a closing PDA, which was looked at by the fellows. This is a mom who was a mom of a baby that was 30 weeker, who we got to see with a closing PDA over time. And she is a pianist, and this is her at Carnegie Hall. So how do you get to Carnegie Hall? Practice, right? And always say thank you to the moms and the nurses for allowing us to learn POCUS on these beautiful babies. And so I will say to you, thank you very much for participating in this webinar. And if you have any questions, please ask them. If you can't get to them, we will get back to you by email or by text. Okay? Thanks a lot.
Thank you, Dennis. Thank you, everyone. We do have a quiz. So definitely I'll launch the quiz right now, and then you can submit your questions in the Q&A box, and we will answer them with Dennis. So you should see the quiz pop up on your screen. And we'll wait until if you have any questions, but if you feel like you want to email those questions to us, that can be done as well. You can email those to pocus@intellios.org. This was recorded, so definitely we'll be sharing the recording after this webinar next week. You'll receive a link, and this will also be posted on our website. So, okay, let's see if there. All right, I see people are answering polls, so definitely feel free to answer those questions. Those are not mandatory, but we felt like this may be a fun way to check your knowledge a little bit, and we'll post the results maybe in about a couple of minutes. But in order to save time, I see there's one question in our Q&A box, how to differentiate between thymus and lung consolidation on POCUS.
What was the first word? Lung consolidations?
THYMUS.
Oh, thymus is
Yes.
always seen, unless it's missing in a case where the baby has the George syndrome or 22q11, they will not have a thymus most of the time, or they will have a hypoplastic thymus. The thymus is right below the suprasternal notch down to about the third intercostal space, and it can be down all the way. It can be behind the heart, the other side of the heart. There's no air in the thymus. So it is a structure that you see as tissue, very similar to liver or to spleen, and it's moving with the baby's respiration. Anything in the lung you see is going to be a reflection of an artifact. So that if you see lung consolidations, they are going to be moving with the respiration, but they are also going to look like little odd shaped structures like pentagons or triangles or circles or whatever. And those lung consolidations go along with pneumonia and severe RDS.
Thank you so much. Let's see, are there any questions we have? I don't see anyone else Yeah, feel free to submit any further questions, and let me double check on the quiz. We still have people answering the quiz, so feel free. I'll give you another couple of minutes to answer those while we still have some time. But if you don't have any questions, thank you again for participating in today's webinar. I just posted the correct answers to the quiz. It looks like majority of you got everything correctly. So for the first quiz question, the correct answer was less than 1%, which is D. For the second question, it was answer B, 10%. Third question, we see the correct answer is, let's see, the correct answer, sorry, I'm resharing the results. The correct answer for number 3 is heart structural abnormalities. Number 4 is mastoid, which is D. And for number 5, we have correct answer, anterior fibrosis terminal. And then number 6 is hyperstenosis. So thank you again, everyone. Before you leave, we have one more quiz question for you. This is a poll where you can share your feedback, and this helps us to plan out future webinars. So I'll leave it that on the screen. Let me see if there's any other questions. Yeah, it looks like no one else has submitted any questions. So thank you again, Dennis, for taking the time to present with us today.
I saw a friend on here, Dan Merton. I want to say hello to Dan. But
okay.
I want to make sure that everybody understands that you can volunteer because you're good at what you do. Volunteer to teach somebody else.
Great advice. Yes, people are asking if we can share the video. It will be shared in about a week. So please stay tuned. We'll send an email with instructions on how to access the video. And this also will be posted on the website. So thank you so much for taking the time. And we'll see you. Actually, we have a webinar next week. If you're interested in lung ultrasound, we have a brand new product that we just released. It's lung POCUS course. And we also have lung certification program. So if you're interested participating in that, please register. We can answer any questions you may have. And again, thank you for taking your time to join us today.